Welcome, everyone. I'm Lydia Chwasiak. I'm a psychiatrist and a professor in the Department of Psychiatry and adjunct in the Department of Global Health here at UW. And I am the co-director of University of Washington's Behavioral Research Center for HIV, or the BIRCH Center, which is bringing this wonderful presentation to you today. Um, and today's topic is integration of mental health services in adolescent HIV clinics in Kenya. It's being presented by our wonderful colleague, Dr. Mugo from Kenyatta National Hospital. He's also a member of Global Watch at the University of Washington Department of Global Health Center. So I just wanted to start, before I turn this over to Dr. Mugo to present, I just wanted to start with a little background about the BIRCH Center, because if you're here today and you're interested in this topic and you don't know about BIRCH, you really should, because we have a lot of this topic is exactly in our wheelhouse of HIV and mental health research. So I think I just have 2 slides, Shirley. We'll go ahead and just kind of tell you who BIRCH is. We are an NIMH-funded 4-year developmental AIDS research center that is based in the Department of Global Health. Susan Graham, our wonderful colleague in the Department of Global Health, is the principal investigator. And the goal of the BIRCH Center, like all AIDS research centers that are funded by NIMH, is to support mental health and behavioral and social science research to end the AIDS epidemic. Part of our BIRCH infrastructure is one of the research cores is dedicated to integrated care, and I co-direct that integrated care core along with our colleague Julie Dombrowski from the Department of Medicine and our colleague Anjali Wagner from the Department of Global Health and Global Watch is also a core faculty in our integrated care core. Our BIRCH mission, I think, is on the next slide, which is to catalyze multidisciplinary research on innovative, impactful, and equitable interventions to promote integration of behavioral health and HIV prevention and treatment across the lifespan to end the HIV epidemic. And so you'll see how perfectly Dr. Mugo's presentation aligns with that. So I'll turn it over to Anjali to introduce today's speaker. So there you go.
Thanks, Lydia. And I'm so thrilled to see so many folks here today. I was ready to arm wrestle anybody who wanted to introduce Cyrus, because as he is my dear, dear friend and colleague who I've known for many years. And last night I had an opportunity to read through Cyrus's CV once more, and I was reminded just of the incredible wealth of expertise and experience that he has. So it's just a true honor and pleasure to introduce Dr. Cyrus Mugo. Cyrus has a background as a medical doctor, as a global health practitioner, as an epidemiologist. He did his training in medicine at University of Nairobi and in epidemiology here at University of Washington. I see some classmates and colleagues here. Cyrus has been involved with a gazillion studies in the last decade, about 20 studies that he's helped design and lead, and many of you have been his colleagues. He has 2 big areas of expertise around HIV throughout the life cycle, mostly focused on children and adolescents. He's led projects that focus on HIV testing and self-testing for children and adolescents, that transition from pediatric to adolescent or adult care, as well as other types of strategies to help healthcare workers deliver care well, like simulated patients. And then he has this whole other body of work in mental health and mHealth. And we'll hear today about 3 studies for which Cyrus is the PI or project director. And they're all very much aligned with the BIRCH mission, focusing on integration of depression or anxiety management for adolescents or other youth through he's the director of the PROACT study, which he'll tell you a little bit more about. He is a recent K43 Emerging Global Leaders recipient for a 5-year Career Development Award. That is the Mindful study, and he's the PI of an impact-funded study thinking about depression for adolescents. I also want to make a note that many of us know Cyrus in a different capacity as a mentor and trainer and teacher. He's been a tutor, a direct mentor, and then a group mentor for so many trainees, including through groups at University of Nairobi and Kenyatta National Hospital, supporting the next generation of researchers to submit grants, apply for Fogarty fellowships, and all sorts of things. So, Dr. Mugo, it is an honor to introduce you, and we're really excited about the presentation you're going to share today. Thanks. Over to you.
Thanks so much, Anjali. I'm grateful that that was recorded. I'll be listening to it a bit. That was very flattering. Yeah, I'm going to share my slides now so that we can discuss a few things. I'll just take a few minutes to go through a lot of work in these three studies, looking at integration of mental health, looking at integration of mental health services in HIV clinics that serve adolescents and youth in Kenya. A lot of this work is informed by a lot of the body of work that we've done, both among children, which were the initial studies that I was involved in, looking at treatment and introduction of antiretroviral treatment for children, and noting the big gap that existed. We were having very good outcomes, especially with testing and treatment for children. We were getting better, vertical transmission outcomes. But we had this big group that was ballooning, of course, across sub-Saharan Africa, more so in East Africa, of adolescents, because we were getting a lot of the children to survive their, early childhood with HIV and become adolescents. So a lot of the children actually took care of, early in my career. We still are doing research with them because now they're adolescents, and this is the area I'm focused on. Yeah. So yes, I'll be talking about the PROACT study. A lot of thanks to the team that allowed me to do this. I think I've seen one of the PIs, Professor Muthoni Mathai. I hope that is you that I saw in the group from the University of Nairobi, and Dalton Wamala also from UON, and Pamela Collins, who is now from UW, is now at Johns Hopkins. And then I'll present the other two studies that PI of. Great. So just a little background. We appreciate the big issue that is the burden of mental illness among adolescents and youth. We've been doing this epi work over the last 6-7 years, and it's been interesting because we got the feeling, very early on, that this is a population that has a lot of accumulated trauma, and we are likely, yes, to get more mental illness among people living with HIV. But adolescents more so, because now this intersects with a lot of challenges that come with adolescence, relationships, and so on, and poorer HIV outcomes. So all these things intersect in a way. And, mental illness does contribute a lot to the poor, outcomes that we've been seeing among adolescents. They're the one group that until very recently remained with a very bad, treatment outcome. And they still have the last 95. For those of you who are familiar with the morning 95, 95, 95, they're the ones who are lagging behind the most with that last 95, especially the adolescents who acquired HIV vertically. We are having a big challenge with that. And of course also higher incidence among the older adolescents and youth, the 15 to 24. Since that is when we now bring in also those who are acquiring HIV behaviorally. So what we've been seeing generally is that the prevalence of mental health disorders is around the 25% mark. We'll see something a little different with PROACT. We are getting a little higher than actually this, and that tells you that the magnitude could actually be much bigger. And there are those who've looked at subpopulations, for example, pregnant women living with HIV, and they're getting prevalences of about 50% for example, postpartum blues. So we know, yes, that we have a big challenge. The burden is recognized, and interventions are required. And we do compare. Many studies over the years have compared HIV positive, HIV negative, and yes, we do affirm that those adolescents living with HIV do have a higher burden of mental illness. So our work really is spot on. If you have to think about it, this is the group that really needs the kind of work that we are doing. So thinking about, what do we need to achieve? And And the biggest questions are no longer the epidemiological questions. We've answered those, or we at least have an idea about the kind of burden and the kind of interventions that are required. And the biggest problems are really implementation gaps. We've gone ahead and developed very good guidelines. For example, in Kenya, we do have the overarching policy, the Kenya mental health policy, which is about 10 years in now, and just about 5 years to go. Talking about the need to provide all these services to adolescents, not just adolescents, to the whole population at the level where they receive all their other care. So thinking about integration, even if those are not the words used, actually, it's mostly talking about integration of mental health services to the primary healthcare systems that we have. And so that's one, very convincing, document that tells us that our work is required. And then we have HIV care specific, documents. And for that, we have the updated guidelines. They updated just 2 years ago, the Kenya HIV Prevention and Treatment Guidelines. And for this, our team, including the UDAP team, were very lucky, for the national, the national government allowed us to contribute to these guidelines, especially on the mental health aspects. Just when we were starting a lot of this work, they were keen to hear how we can contribute, and we provided all these, answered a lot of questions on tools, for example, that could be applied and could be used in the HIV setting and so on. But the one that is very specific to the adolescents is the one on the left. That is the adolescent package of care. And it speaks, even if this, actually what we have currently is 2016, we just helped, NASCOP develop, the new iteration. And this will not just take care of adolescents living with HIV, it also includes other adolescents, and placing mental health care really in the center of prevention and also treatment, and thinking about the treatment support that is required. So we can also think about global health, what are global targets? And there are guidelines also, telling us that by 2025, we need to have established for all people living with HIV, at least 90% of them. That's another 90 we will hear of, apart from the 395s. 90% of people living with HIV need to be receiving what they describe as people-centered and context-specific integrated services. And mental health services play a big role in ensuring that you provided holistic care. And so for Kenya, in brief, what we're required to do is screen, at least provide some screening for mental health, depression at least, and provide some psychological first aid for those who require it within the clinic. And then for those who require specialized care, of course, establish an HIV specialist interface. There are big gaps in all these areas, and this is why these studies are still necessary. So let's start with screening. And the first one we'll talk about is the work that we've been doing with the University of Washington Impact Center. The center did award a pilot study to myself and my mentors. And Dr. Shannon Dorsey, Dr. Brian Weiner, they were looking to pilot some of the methods that are developing in the center. And this interfaced very well with the work that we are doing here with mental health. And just thinking about some small piece, how do we get screening to become routine and integrated in the HIV clinic as the first step towards integrating mental health services? So the aim or the aims of this pilot study were to look at the methods that were developed at the Impact Center and see how we can use them to improve our services here in the HIV clinics for adolescents. And so we to look at barriers to implementation of depression screening among adolescents with HIV as our first aim. And the impact method that we were to apply there were using rapid evidence review and also stakeholder narratives, and we'll discuss that. And then there was the barrier prioritization. So we've got barriers to implementation. How do you prioritize these barriers so that you can address them systematically and effectively? And we used, again, stakeholder work to do that. and then identify strategies to deal with these barriers that we've identified, and then rank them, utilization of nominal group techniques within workshop settings. And then lastly, developing implementation roadmaps. Again, a mix of stakeholder work and technical researcher work. So yes, we conducted a rapid evidence review. There was nothing rapid about it. That was our realization. We put in so much work. It's basically just a systematic review that we've called rapid evidence review, but with one caveat. Yes, I think here you're allowed, generally, my interpretation of the method was that you're allowed to move quickly from, whether it's the PRISMA guidelines, and interpret generously to your time. So for example, if we found an abstract really did not talk about barriers, we excluded it very, very quickly, or did not talk about strategies. We did not do a lot of reading, and we went straight to the ones that were really talking about what are the barriers to implementation, what are the strategies that could be used. And we found 19 articles that we've summarized, and I'll give you some of those results. We then held a 2-day workshop earlier this year. We did this work only in Nairobi, limited the workshop to only 11 members so that we could have more time for everyone's participation, but also try and get as good representation as we could. So we had the HIV leadership of the Nairobi County, the mental health program leadership within the county, and then we also had frontline providers, and we also had representation of the youth. And in this workshop, we did 2 things. We did barrier prioritization, and we also identified strategies, and also thought about how do we build an implementation roadmap. And that is what you see. We discussed mechanisms, we discussed preconditions, and we discussed moderators. So what were the barriers that we found? So the stakeholders, looked at the barriers that we presented to them through the, rapid evidence review. So we compiled those and, just jotted them down. This is what the literature is saying on barriers to implementation of screening, specifically just thinking about the PHQ-2 or PHQ-9 or any other tool within the HIV care setting. But then they also now looked at those and said, this look like they work in our context. These are the issues we have in our context, and elicited additional barriers. And more importantly, they actually decided to cut out some of the barriers. So one of the things that we actually did for most of day one was actually saying, yes, we've talked about this barrier in literature, but in our setting, this doesn't seem to really apply. This is not a problem you're dealing with. Versus we have all these other barriers that we can spend our time on. So we settled on 33 barriers that were relevant to the context, and they were organized into patient level, or provider level, organizational level. That was our thinking as researchers. And then our stakeholders actually said, we actually think there could be more levels, and they added 2 extra levels. That is socio-cultural, and they wanted to separate this from just, say, patient level or provider level, and also separated organizational level with structural, so that you're not conflating the 2. They thought they are pretty different. So these are examples, the examples of provider level barriers. One that they found uniquely to the HIV clinic was lack of knowledge on how to actually administer the PHQ-9, which is actually now required to be the standard of care. And they actually raised this, we've not actually been trained on how to administer this tool. A patient level barrier was a knowledge gap on mental illness. So it becomes difficult for the provider to start the screening and for this to be a meaningful exchange if they actually don't understand why this is important for them. At organizational level, they did talk about inadequate resources. For example, are the tools available? If you don't have an electronic medical record system and you're using paper, are the paper forms of these tools available? And another very important one, which is a complicated referral system. They actually don't understand, if I screen you, where do I send you? And so basically people avoid screening because they don't know how to move to the next step. If I find that you have a severe mental illness, what do I do with you? And that's a barrier to screening. And that was an interesting one to find actually also in literature, very well described. And then sociocultural level were questions about stigma for mental illness. And this is both at provider and patient level. And then policy or structural level, this is the question of where do we do screening? Are the guidelines too rigid that, for example, yes, we do screening within the clinic settings, but are we actually allowed to do it in the community spaces? And that was an interesting one too, to think about. We've got all this outreach, HIV treatment support work. Could this screening actually be done out in the community? And so we had an informal process, just asking, of all the barriers that you've mentioned, what do you think is your top three? And this is an informal barrier prioritization way. And this would be the normal way in which you would go to a clinic and say, what are the challenges you're facing here? And what was placed at the very top was patient knowledge. They thought patients not knowing about mental illness was the big reason why we don't screen. And you'll see how that changes when you do the formal process. And then they talk about stigma, especially stigma related to the patient. The patient feels stigma they don't want to talk about mental illness, and they stigma around that. And they felt that this was the other big barrier. And then provider knowledge on mental illness, not necessarily on screening, but on mental illness. So you can see that these were the big, barriers that they thought informally, just out of their heart, these are the ones that I want you to address. But then we went into a formal, prioritization, and we used the optic methods, the impact methods, and we had all these, rating criteria, 6 criteria, talking about importance, frequency of the barrier happening. Is this barrier addressable? Thinking about timing. Does this can you address this barrier now? So it's not just that it can be addressable, but are you able to address it now? It's something that you have to do much later. Talking about duration, how long does the barrier persist? And then talking about equity, to what extent that this barrier, contribute to inequitable implementation, and especially thinking about minority groups. And we also had the privilege of deciding of all these criteria, how much weight do you place on them? And the stakeholders felt that how they've rated each barrier on importance should be the one that gets the highest weight. That is why they feel that they have the biggest emphasis. How I rated the barrier on importance should have the biggest emphasis, followed by whether it's addressable, then followed by whether it occurs more frequently, the timing, whether it can be addressed now, and then to the very end, a little weight can be given to how long the barrier has persisted. And this group actually said, from how we've rated equity for these barriers, we actually do not want to consider it when you're doing the math on whether these barriers affect us or not, implementation of screening or not. This was an interesting discussion that we had, but I think that is our context, that they felt that equity was not a big deal in this context. And examples of what we got at the very top of the list was provider knowledge on screening. That is the one that eventually was placed at the very top, now after doing this formal process, followed by provider knowledge of mental illness, and then followed by stigma for mental illness. If you see, provider workload comes at number 4, having a complicated referral system at number 5, and then poor client attitude towards mental health comes at number 6. And we had many other barriers that were rated, but these were the very top. And you can see the differences. After you do the formal rating, provider specific barriers are the ones that actually came to the top. Provider knowledge on screening, and then provider knowledge gap on mental illness. And then, of course, we had the stigma one also sneaking in, and that was also rated earlier in the informal process. So yeah, so we did that process, got our barriers, and now we discussed our strategies. And the strategies, we had some from literature, organized in the same level. So we were looking at, so we have one barrier. What are the strategies to overcome this barrier? So we classified them in the same way we classify the barriers. So there were patient level, how do you deal with, what are the strategies to deal with patient level barriers and provider level barriers and so on. And examples of strategies that we got from this group were, for example, if you look at provider level, thinking about developing a scheduling system that helps reduce provider workload. So they're thinking about a barrier like, in high provider workload, and you're thinking about screening, and having a good scheduling system for patients to come into clinic would help in reducing the workload. Thinking at patient level, something like having health talks, so education. I think that is where you would put it when you're thinking about some of the implementation strategies. Thinking about organizational level, so introducing telehealth, sociocultural, level barriers, address them using adolescent-friendly language, or applying social media to tackle stigma, for example. And then there are policy or structural level barriers, and how do you address them? And an example is thinking about the school curriculum, and that may be beyond us, but that is the example that they gave. So we also did an informal process. So among all these strategies that you've stated, which are the ones that you think you can carry out, right now, and move ahead? And they thought that low-hanging fruit were capacity building for providers to screen, sensitization of adolescents to improve knowledge, so basically the health talks, and then training providers to improve knowledge on mental illness. And then we had the formal process, now using the just checking on time that, yeah. So the formal process included feasibility. So you rate on feasibility and then rate on potential impact for each one of the strategies. And these are the ones that came out on top. So the top strategies were improving provider skills on mental health screening. So basically that training. And then to improve provider knowledge, they actually felt that training would not be effective. Provider knowledge on mental illness, but reviewing cases of mental illness that have actually been diagnosed by the mental health teams, and then taking the HIV clinic teams through a multidisciplinary team meeting, either at the sub-county level or actually the facility level, would help in learning about mental illness. And then to address stigma, use of support groups came out on top. And so, yeah, so the ones, yes. And so those are the ones that actually were ranked, the top ranked strategies. Having a multidisciplinary team to deal with mental illness knowledge gap, capacity building to deal with screening knowledge gap, and then support groups to deal with stigma. Now, this is work that is ongoing. We are now using this knowledge to think about, so we have a strategy. How do you actually implement it? How do you actually go about implementing that strategy so that you can achieve the outcome that you desire? In our case, the outcome is that we get as many adolescents as possible provided with screening that is proper and actually is able to pick mental illness. And this is now where the K43 actually comes in. So this is the work that we'll be doing over the next 5 years. Something very similar. We've learned our lessons on how to conduct barrier prioritization. We've learned our lessons on how to conduct development of strategies. And our aim one for the K will be to identify determinants for implementation of screening. But we also added something additional. So we're not just going to identify determinants of implementation, but also HIV, the referral. So the HIV clinic specialist interface. What are these strategies that would really help in seeing a referral process that makes sense? And then our aim two will be to prioritize these barriers, and of course match the barriers that are rated highly to feasible implementation strategies. And then we'll go ahead and test and cost the highest ranked strategies over a period of 2 years. I'll come back hopefully and present the K in more detail. So that's screening. And that is the first part of integration. The second part is thinking about within the HIV clinic, how do we provide at least psychological first aid, or actually, how can we provide comprehensive care to adolescents who need it within the HIV clinic? And the K, of course, can address that interface with specialists. But the PROACT study, which is now the one that we're discussing, is looking at transdiagnostic psychological interventions. And why are we talking about transdiagnostic psychological interventions? We already know that psychotherapy, which is what is recommended for mild, moderate, severe, cases of psychological distress, whether it's depression or other disease entities, is effective. And we have a whole body of literature that shows that treating depression also improves HIV outcomes, so that it's adherence or viral suppression. So we've got some good evidence moving forward. And we also have learned a few other things. So the mental health illnesses don't just show up as disease specific entities. So a person just having depression or a person just having anxiety. So a lot of these diseases actually intersect. So there is the crossover effect of the disease symptomatology across depression, anxiety, behavior, trauma, and so on. But there's also something else noted in literature, that a lot of the psychotherapies that we have a transdiagnostic component. So while an intervention was tested, evaluated, made for depression, it can also handle some symptoms, some trauma symptoms, some anxiety symptoms. And this is what a lot of the tested psychotherapies have shown. Those ones that have been tested in Sub-Saharan Africa, again, by the UDA team, the CETA, among adults has shown the same properties. And trauma-focused CBT, cognitive behavioral therapy, has shown the same properties. And this has been done among adolescents, including here in Kenya. But one of the things that we know is that these are lengthy, interventions, 8 to 12 sessions. They probably would require weekly visits for them to be effective. But something else has also been shown because of the failings to keep to this very rigorous intervention. We have seen patients who only come for, say, 6 sessions. And maybe they're not every week or every 2 weeks, so they are spaced out. But the evidence from CETA, the work in Mozambique, actually did show that there was more than 50% reduction in symptoms, even where patients only had about 6 sessions. And that's good. I think that's good evidence that having brief interventions, abbreviated interventions, could also be useful. And more so in our HIV clinic settings and adolescents, where we are dealing with a group that usually will be in school. And so keeping to those weekly schedules, many sessions would not be feasible. So the PROACT study is an abbreviated trauma-focused, or maybe a CBT, just CBT. It just takes 5 of the CBT modules, and we are hoping that this does impact across many disease entities. So that's psychoeducation. We do relaxation, problem solving, behavioral activation, cognitive coping. All these are some of the themes that do exist within the CBT framework. So what are we thinking when we are introducing this intervention? So the HIV clinic and the adolescent is unique. The sources of poor mental health are like many other populations, but we do expect that there are unique risk factors. For example, HIV stigma, that's a big one that is very unique to the HIV population, and more so the adolescents. Violence, while not unique to the HIV population, it's much more a bigger burden within this population. Poverty, we know the HIV affected populations also have higher levels of poverty. And we are talking about challenges with parenting. We have very high rates of orphanhood within this population. We are having a lot of them caregivers also affected or living with HIV within this population. And so there are many reasons as we can think about that, and all these are multi-level, that could be a problem to the adolescent and propagate poor mental health. So our hope is that the intervention, which is PROACT, does address some of these risk factors, improves what we would now call the PROACT skills. So the person is able to understand their mental illness. If they've got anxiety symptoms, relaxation is there. They're having challenges, going through life with the challenges in life, how to communicate these problems. So problem solving and communication. They're having challenges with coping with whether it's taking drugs or HIV stigma. So all these are modules that provide specific skills to them. And we're hoping that we impart these skills through that intervention, and that, we get improved mental health outcomes. And we're hoping for the three, at least we are testing the depressive symptoms, anxiety symptoms, and trauma symptoms will reduce with this. And in turn, that helps with health behaviors, that is improved clinic attendance, improved ART adherence, and ultimately improved health outcomes, and that is viral suppression. And we think this may be moderated by other factors. The success of implementing the skills that you have could be impacted by, how you're attending school, how are you doing in school, what kind of support do you have in school and at home, and also the question of the provider competency. And also self-efficacy. These things do come into play when you're thinking about the success of the intervention. So for the PROACT study, we have three aims. The first one is to adapt and optimize the PROACT intervention. And we already did this through a heavy stakeholder-led, aim one that was done in year one. And the stakeholders who we had about 50, about 15 in a conference, and working in small groups, thinking about all aspects of the intervention and its implementation. And they really did help us think about the unique HIV care setting for adolescents and how to shape this intervention. And so that is done. And then now we are in aim 2, we're doing evaluation of the effectiveness and implementation of PROACT. And yes, we are targeting the 16 to 24 years. And I know a big question usually is why we are not dealing with the 10 to 15. And usually the HIV care setting, there's a big issue of disclosure of HIV status, which is a big question also when you're thinking about risk factors for poor mental health. And so we hope that we can deal with this younger age group with a different study. And then we're also collecting data on costing and a lot of data on implementation. So this is, just to think about the intervention, we are calling it PROACT, the PROACT study. PROACT is basically just the acronym for the 5 modules. 6? Yeah, 6, maybe 5 modules, yeah. And we're delivering this in person with an option of doing phone delivery in case we get into problems like we had in the last few years with COVID. We do have that option. And then who is delivering this intervention? So these are trained non-specialist providers. So these are people who do not have mental health specialist training. They're not psychologists. They're not psychiatrists. And that also includes that they're not nurse psychiatrists. And so we've trained this group. We are targeting the adolescents with psychological distress. We are targeting between 4 to 6 sessions to complete them over 6 months rather than just 6 weeks. So we are doing between 6 and 6 months. In case someone is able to do weekly sessions, that's totally fine. But thinking about the cadence of clinic visits for adolescents, we are giving leeway to finish this in 6 months. And of course, our outcomes are the 3 disease entities. And this is the design. We have 30 clinics. So this is a cluster randomized clinical trial. The 30 clinics have a combined about 2,400 to 2,500 adolescents and youth in this age group. We'll do screening. Screening is being done by study staff using the PHQ-9 and also questions on suicide using the Ask Screening Suicide Screening Questionnaire. And so we basically segregate people into 2 groups. Into 3 groups, we could say. If you do not have any symptoms, you're not enrolled, you're not eligible. If you have mild to moderate symptoms, you're enrolled. If you have severe symptoms, you're enrolled into the study, but also referred to a specialist. And severe symptoms also include if you've got any suicidality at all. That also gets at least a referral to a specialist. So the clinic staff take over from here. In the intervention sites, we will have about 300 enrolled, and those ones will be taken through PROACT. In the control sites, again, another 300 will be taken through whatever standard of care is available to them. Just to note that those with severe symptoms, whether in intervention or control sites, get a referral to a specialist. And we measure our outcomes at 5 points: baseline, month 3, 6, 9, and 12, and also measure our secondary outcomes being treatment adherence, at the same, with similar points at the primary outcome, and viral suppression at month 6 and month 12. And this is how we are measuring our outcomes. Depression, we're using the PHQ-9. Anxiety, we're using the Generalized Anxiety Disorder 7 tool, the GAD-7. And for trauma, we're using 2 tools. For those who are below 18, we're using the CATS. And those who are above 18 and above, we're using the DSM-5 tool, the PCL-5. So how was the training? Very rigorous. 8-day training in person, with 1 day where we basically did a sensitization of the providers in the intervention site. So we had a lot of providers come in and give them an overview of the training that will go on. And then we were left with those ones who will now implement the intervention, where we had a pre-training competency assessment, and then a training on the competencies that they'll be required to have. And then we have a 5-day training specifically on ProAct and how to deliver ProAct using didactics and role playing, a lot of role playing. And then we had another day where we did, an assessment, to basically a post-training assessment to see where they've reached. But then the training did not end there. We had a 3-month period of practice where they met with a supervisor, they're basically the same trainers, and they went through the steps and their step sheets of how to deliver the intervention, and also got practice clients within the clinics. Did some screening and got someone who's got some psychological distress, and then they were taken through sessions as they were being closely supervised. And the training has not ended, even as we say that they are now implementing, as I say next. They're still receiving support supervision. So our groups are 3 because we're in 3 counties. We trained the groups within the counties: Nairobi County, Kisumu County, and Homa Bay. And in each of the counties, we have 5 facilities, each of them giving us 3 providers to, these are the 5 facilities within each county in the intervention site, giving us 3 providers to train to implement this intervention. And they're all non-specialists, and the trainers part of the research team and also specialized ProAct trainers. We are, as I mentioned, we are collecting a lot of implementation research data. We are looking at determinants of implementation using the CIFA, the Consolidated Framework for Implementation Research framework. And we are also collecting a lot of data on implementation outcomes, especially on reach of screening and reach of the intervention. Questions on adoption, questions on implementation fidelity. We are measuring fidelity quite rigorously, actually. And then questions on acceptability and cost, of course, of the implementing this intervention. What's our progress so far? As I mentioned, we've done adaptation, we've done site selection, we've gone to the ground and looked at facility characteristics and readiness, we've done flow mapping, we've done time in motion to get to know the time that providers take with the patients. We've done randomization so that we have 15 sites in intervention and 15 sites in control. We've done provider surveys to basically understand their competencies, their work history, organizational readiness. We've done training, and we've started the cluster randomized trial. We are 2 months in. And so far, we've actually enrolled more than 150, which is more than 25% of our enrollment. We are hoping, we'll go slow, but we are hoping that within the next 6-7 months, we'll have reached our target of 600. So a snippet of the results. We've got about 30% prevalence of psychological distress just using the PHQ-9. And of those, about 10% of the people we screen actually have moderate to severe symptoms. So this is a real problem. And we do appreciate the fact that we are actually getting this in these clinics. And yeah, so this is the team. You'll see a lot of the team, working in ProAct there. And some of them, in the meeting today, like Anjali, who was not in this meeting. I would like to acknowledge the ProAct team, the MPIs, Dalton, Pamela, and Muthoni, the co-investigators. We are doing a lot of this work with the HIV program, NASCOP, and the clinics, Nairobi, Kisumu, Homa Bay, the county leadership teams, the study staff, clinic staff, adolescents who are very responsive to, our request for them to join the study. And of course, our funders, NIMH. And I also thank the UW Impact Center, Shannon and Brian, and Judith, who I think is in the call, who really did a lot of the work in this pilot. And then the Mindful study, which we've just started up with my mentors, Irene and Shannon, and co-investigators, collaborators in Homa Bay, whom we're going to be working with in the National HIV Program. And this is also funded by NIMH and, of course, the Fogarty International Center. I'll stop there, Anjali, for questions.
That was fantastic. Cyrus, it is such a joy to hear all about these wonderful studies and see how they each lead to each other and all of the lessons learned along the way. And what a spectacular team. At this point, we'll open it up for questions. I already see a hand raised from Eliud. So Eliud, go ahead. And if you feel able to come off mute and ask your question, go for it.
Thank you so much, Anjali, and thanks, Dr. Cyrus, for this lovely presentation. I just wanted to find out if for the adaptation, did you do any design workshops or did you engage, especially looking at adolescents, were they at the center of this? I ask this because it's a question that someone would want to know, like, have your product approach really placed the end user at the center of how it will be applied?
Yeah, thanks for that. Yes, so actually that has been, an important part. So before we actually took this intervention to apply it to the HIV clinic setting, the team led by Prof. Muthoni and Pamela had actually done this work with youth not living with HIV during COVID time, and they had done a lot of work with youth and trying to refine it and see whether it works. So, and then they actually went ahead and also used it in another setting, still within actually Western Kenya setting, and they also got a lot of feedback from the adolescents. This is what we think about the intervention. And so even when we were coming into this clinical trial, we had a pretty good idea about what they felt. But we went actually a step further, and during the workshop, of course, they were at the center of it. They very youthful. A lot of these are actually adolescents living with HIV. You'll see here, who came in and they gave us, and they were in this, working groups to basically review this intervention. But we also formed a community advisory board, which has a big representation of youth, and actually chaired by one of them, one of the youth, and the secretary is also one of the youth. And these are the people who are actually taking us through every step of implementation. So yes, there's a lot of youth, and also something else. Some of the youth, we actually got them into the study team, and some of them are actually working on the data side because that was their skill set that they brought into this, and they actually working quite a bit with this. So I hope I've convinced you that we involved youth.
Thank you so much. Good. I'm convinced. Yeah, thanks a lot.
Great.
What other questions do folks have, Eliud? That was a fantastic one. I'm going to pause for a moment to see if there are any hands raised. Okay, I'm going to take a question that's in the chat. And Nak, I'll read this aloud because I assume you are not in a place to share it now. And then I see one other from Ravi, and then Cyrus Mugo, I see your hand. So Nak notes, great presentation, Cyrus. I was wondering if it was coming up during the implementation of the study, if the PHQ-9 was considered the tool to measure depression, mental illness in this population. I ask only because in the DISC study, it was interesting to hear that some providers did not feel like the PHQ-9 was the right tool.
Absolutely. This debate has, and this was one of the biggest debates in our stakeholder meeting, because I also did go in thinking that this is not the right one. But two things I can say about this. We've applied PHQ-9 in quite a number of settings. And I know I looked also at the DISC data, and you could see our prevalence, especially for moderate to severe, depression was, I think, 4-5%. We're actually getting about 10 to 15%. In some cases, in facilities, we're actually getting about 20% of moderate to severe. And this is an interesting one because what it's come actually down to is training, how to do the screening using the PHQ-9. And we had a lot of these conversations in the stakeholder workshop where providers would say, when I do the PHQ-9 and then I talk separately with the adolescent, I get two different results. And it actually boiled down to, are you actually administering the PHQ-9 the correct way? And that is what we're actually seeing with the implementation of the study now. If you do it correctly, you're actually able to pick the depressive symptoms. But there's something else. We will actually do specific analysis to actually see whether PHQ-9 eventually is the right tool using the data that we are collecting a lot of this data, and we are hopefully going to advance science by giving that answer. How well does the PHQ-9 perform as a screener for this population?
And there's a follow-on question, Cyrus, that Ravi sent in the chat, which was about adaptation. If there's any planned adaptation for the PHQ-9 or any of the screening tools, which you started to address now, but I imagine after you do that last analysis that you alluded to, you might have an opportunity to engage in any adaptation needed.
Yes, absolutely. Yes. So one of the things that we are doing now, of course, is the translations, and many people have done these translations. And we will see how that works. We are getting, lived experiences with people who've used the translations, but we will see how this works out in this study. So I think we'll give better feedback on whether the PHQ-9 actually, because we're actually doing even these other screeners, the anxiety screening, we're also doing trauma assessments, we're also doing many other assessments, and we'll see whether the PHQ-9 actually fits in that sweet spot for adolescents. Yeah.
Great. Thanks. Sarah, you have a question. Go ahead.
Yeah, thanks so much, Cyrus. That was really an excellent presentation. I enjoyed seeing how you've applied the mechanisms, the barrier strategy mapping, all of that. That's excellent. So my question was actually on just the criteria for the prioritization, and wondering if I see that you probably decided what would be weighted and what would be the top priorities after they already did it. Was that by design, or would you have wanted to do it before? I was just curious about your thoughts around the decision. Do you think that after they rated, they swayed, or would it have been different if they
If they
chose
decided
before,
Yeah, thanks
prior
for that.
to?
Yeah. How to do the weighting? That's a good question. We basically are just following the manual and deciding, okay, yeah, we know what importance we'll be measuring, and we know what addressability will be measuring. And we really wanted them to actually first tell us that they understand by doing the rating themselves. And so I think that is the reason why we went after. After that, after you've done the rating, tell us whether importance is the one that wants more weight. It's a good question on whether they should think about the meaning of these domains and then actually weight it before. We actually can try that with a K, and so that we get different results. And then we can actually compare with what we did with impact. I know the other studies that have done this weighting have also done it. From what I've read, they've also done it after the rating was done. But that's a good point, Sarah. Yeah.
Yeah, I don't think I was just wondering about that, because I was like, most of the time after you know something,
Yeah.
you might change your mind. But yeah, that's good. Thanks.
Yeah.
I see a question from Muriel in the chat. Are there any plans for scaling this up for a new context or additional countries?
Yes. So is scaling up. So scaling up, yes. There's a lot of work we have to do in thinking about scaling this within the HIV care setting, and of course the young adolescents thinking, and also thinking about adults, and also thinking about beyond the HIV care setting, so the primary health care setting. And so this actually becomes a very good laboratory for integration of mental health services into the primary health care setting, which I think Kenya right now we have that as a buzzword, of course, primary healthcare, universal healthcare. So this could actually provide that platform to think about that scale up. Hopefully, future grants will think about that.
I'm going to go back to a point that Nak made earlier in the chat, which was thinking about how things are different, either the screening tool or potential scalability. I'll add in my question there. If you think about screeners or therapeutic interventions being delivered by adherence counselors versus higher level providers, and if you think about like task shifting within the potential for scale or the fidelity to screening tools.
Sorry, was that a question? So sorry, I didn't get the
Poorly
question.
worded question. When you're thinking about like scalability of this type of
Oh,
screening
yeah.
and therapy
Mhm.
intervention, do you think about the cutters of folks that might do it? Do you
Oh,
have any
yes.
concerns about fidelity for different levels of providers?
Perfect.
And might there
Yeah.
be a trade-off for getting broader scale?
Yes, and this is the discussion we're having so much. So every day with Shannon and the mental health team, how much intensity is required so that this is delivered, and the person delivering it, it's a safe intervention. So I think that is the biggest question. Thinking about psychological interventions, you've got to be safe, so it's got to be delivered very well. But at the same time, does delivering it well, what does it mean in terms of costs? What does it mean in terms of provider workload? What does that mean in terms of um, you know getting the adolescents actually to accept this acceptability of the services? So hopefully all this implementation work that we are doing will inform the scalability question. And I know we'll do all those nice questionnaires after in interviews, but I think collecting these outcomes iteratively as we are going on, I think will really help us understand. It's a whole jigsaw, because we are thinking about, do the screening well. Who does the screening well? It's a person who is very, very well trained. Who does the intervention? It's also going to be someone who is very, very well trained. And then, of course, you've got to think about a specialist interface that allows for supervision and easy access to specialized care. So yeah, there's a lot of questions, of course, that emanate from this. And hopefully this team, of course, and a lot of the other teams can pick this work and run with it.
Thank you, Cyrus. I just want to appreciate this fantastic discussion. I'm going to pass it over to Lydia to close us.
Yeah, no, wonderful, wonderful presentation, Cyrus. Thank you so much for sharing your experience and your wisdom, and thanks for great discussion, great questions. So as Shirley said, recording of this session will be on our BIRCH website, and just a sneak preview, if you enjoy listening to Cyrus present, he and a colleague from Kenyatta will be presenting a policy workshop in a couple of weeks on October 17th. So we'll be sending around notification about that. But thank you all so much for joining today. And thank you again, Dr. Mugo, for a wonderful presentation.
Thank you too. Thank you.